Good morning, everyone, and thank you for joining us on this Placenta Side Training Day. And I wish I could be there with you guys in person, but I had some last-minute family things to take care of. I'm really sorry, guys. So in this section, I'm planning to explore a condition that has become increasingly relevant in our obstetric practice called placenta accreta spectrum, or PAS. So this spectrum range from accreta to increta to parcreta, posing significant challenges in our diagnostic and management plans. So as sonographers, you guys play a pivotal role in early identification, often making the huge difference between a planned controlled delivery and, if we don't recognize it, a life-threatening obstetric emergency. So we'll be looking through the risk factors of PAS, epidemiology, and most importantly, ultrasound features that we need to recognize. I'll also touch on how PAS intersects with conditions like placenta previa and the impact of rising cesarean section rates. By the end of this section, I hope we'll feel more confident in identifying suspicious features of PAS on scan, knowing when to escalate and refer, and understanding just how critical your role is in the diagnostics and management of this high-risk pregnancy. Okay, let's get started. So, what is PAS? PAS essentially means, as the definition here says, abnormal adherence or invasion of the placenta into the myometrium. So to understand that, let's start with the uterus normal layers. So usually this is baby's placenta, fetus side, maternal side, attached to the uterus endometrium. So uterus has 3 layers. Endometrium is the innermost lining, and then there's thick muscle layer, and there's a thin plastic-like surrounding layer called serosa. So in normal placenta, it attached to just the endometrium. In PAS, it invades right through the endometrium and attach directly into the muscle layer. We call it placenta accreta. So attached to the myometrium but not invaded. If it invades, it becomes increta, and sometimes it invades right through the muscle layer and then protrude outside into the serosa layer, and you can see it from outside of the womb like a little barging of the placenta, blue thing, that is parcreta. And in some cases, it can even invade to adjacent organs like the bladder. So this invasion, it could be like total, the whole placenta attached on the whole of the womb where it placenta attachment is, or it could be just partial or focal in one side and completely normal attachment on the rest of the areas. So it will determine how it will affect the management. If it is the whole layer, it might not bleed, but the placenta cannot be removed or separated, and it might need hysterectomy. In some cases, we don't know because it's just very partially accreta in one area. The rest are like completely normal, so it presents as like started bleeding when we try to separate the placenta, and only a portion of placenta gets attached, like really adherence placenta, and came like retained placenta, and we have to take the patient to theater and only then realize it. So our main goal is to differentiate between placenta that will easily separate and ones that will invade more, stubbornly, placenta accreta spectrum. And we don't need to exactly determine if it is accreta, increta, or parcreta, because it's essentially a histological diagnosis. Only when a woman needs a hysterectomy and uterus is sent to the pathologist, and they can tell us exactly what level it is. But in some cases, if we start suspecting and we did MRI, then we might be able to differentiate the invasion degree. So just how common these placenta accreta spectrums are. So it's quite rare in general population, 1.7 in 10,000, so it's like 0.017%, 0.01. So it's quite rare if you have no risk factor. So what are the major risk factors? So here we've seen previous cesarean section. That's the most common risk. It increases drastically. If one prior cesarean section, the risk is about 4.1%, and if 2 or more, it can increase to 13%, and even higher with more cesarean sections. And it doesn't even have to be cesarean surgery. It can be just multiple DNC, uterine curettage, or myometemy, or even like previous retained placenta and we remove the placenta manually. Manual removal can be a risk factor for PAS. And we also found that high parity, loss of children before advanced maternal age, IVF, these are also risk factor for both placenta previa and Accreta spectrum. And obviously in this pregnancy, if a woman have a placenta previa, it increase the risk as well. Placenta previa plus cesarean section increase the risk. And obviously if previous placenta Accreta spectrum and the women did not end up hysterectomy and get pregnant again, the risk is higher. So it's 22 to 29, like 3%, 30%, like 1/3 of the women who had previous some kind of Accreta can have like another PAS disorder in this pregnancy. So how do we diagnose this placenta Accreta spectrum? Routine screening is essential. So during our 18 to 22 week anatomy scan, it's critical that we ask every woman if they have previous cesarean deliveries, any uterine surgery like a myoma removal or multiple DNCs or previous manual removal and such, any like risk factor for PAS. If they do have them, then we need to have a careful placenta implantation site assessment. So the ultrasound should be performed with a full bladder to optimize our visualization of the lower uterine segment. And then we'll go in more details what things we're looking for in the scan for the placenta Accreta spectrum. And then if we have any suspicion of PAS, or if a woman has low-lying or placenta previa with previous scar, or even if it is not low-lying, if it is covering the scar or any of the risk factor that get suspicious of PAS, then please refer to FMU. And then after in FMU, we'll have the specialist evaluation with the TVS and 3D 4D imaging, and if necessary, complemented with MRI. And then we'll also refer to a center specialized in prenatal diagnosis of PAS if we confirm or diagnose it. And it will be St. Mary's for our region. And then we can have comprehensive management planning. So this targeted screening, by asking the woman a little bit more history and then do focus risk assessment and then referral and evaluation, it will use our resources more focused on the women with highest risks while not compromising with detection rate. So early detection is vital. We've already gone through, we're going to try to identify PAS in routine anatomy scan, and sometimes it would be first time to detect it in the growth scans in the second and third trimester. Early recognition is important because so that we have a time for comprehensive management planning. So for delivery timing, if it is PAS, we tend to deliver between 35 to 36 plus 6, 37 weeks. Before 37 weeks, and we need to book for triple slots in C-section list. Surgical approach, sometimes we might need to tie in like gynae consultants if we are planning for potential hysterectomy, and even multidisciplinary involvement like getting interventional radiologists for femoral artery embolization or something like that, and blood products management with cross-match 4 units, let the hematologists aware of that. So we need to do a lot of planning. So timing and early recognition is important. I already went through when to maintain high suspicion, like low-lying placenta with previous scar, anterior placenta covering scar, multiple scars, or unusual appearance on routine scanning. Even at any gestation, detection is important. So optimal timing and approach, we already gone through timing. Aim for mid-trimester. Earlier detection, in some units they try to detect PAS in first trimester, but second trimester is okay, it's optimal. We still have enough time for planning. Comprehensive approach, in addition to transabdominal, we prefer to use transvaginal as well if necessary. And also color Doppler is essential, should be employed routinely for assessing women with risk factor, and plus or minus MRI. Serial evaluation, some cases we're not quite sure, it's suspicious but not definitive findings, so serial ultrasound assessment, we might need to book more scan every 2 to 4 weeks, as some of the findings will become more apparent with later gestation and placenta invasion. So sonographers' critical role. So we're the first line in detection of this life-threatening condition. Timely referral is important for problem management and documentation. So thorough imaging and reporting will improve our team preparation. So what are the signs? Sonographic diagnosis, essential signs for placenta accreta spectrum. So according to Israel guideline, on the 2D gray scale, these will be loss of the clear retroplacental zone, myometria thinning less than 1 millimeter, abnormal placental lacunae. We'll see how it is different from placental lake, and bladder wall interruption, placenta bulge of this focal exophytic mass. So these are the 2D signs. With the color Doppler, we can enhance our imaging. We can see hypervascularity either in utrovesical or subplacental hypervascularity, bridging buses, placenta lacunae feeder buses, and 3D hypervascularity. And presence of multiple signs increase diagnostic accuracy, and obviously color Doppler imaging will enhance detection by visualizing the vascular pattern characteristics of the invasive placentation. So let's get to the more interesting stuff. Start with images. Loss of retroplacental clear zone. So what is this clear zone? Is this little black area, hypoechoic retroplacental zone? It is in normal placenta, we should see it. And if it is not seen, and then it's suspicious of PAS, and this sign is found in this loss of black area is found in 70% of PAS. It's the loss of the decidual layer, and it's the earliest and most consistent signs of the abnormal placenta attachment. So like placenta attached directly into the myometrium. Let's play some video. Can we see? So we usually press myometrium and clear zone, and then release, and then you can start seeing this little black area more clearly when we release rapidly. So this is the normally clear zone, how to detect it. If we cannot see the clear zone, then it's more likely to be PAS. So the next one is myometria thinning. So we can see placenta, the endometrium clear zone, and then there's myometrium and the bladder. If this myometrium is very thin, less than 1 millimeter or undetectable, we start suspecting PAS. It's found in 50% of affected cases. Especially important when we want to see the site of the previous caesarean scar, that there stay myometrium layer there. So here you can see myometrium thickness after 1 C-section, a good size, but after 3 C-section it's like very thin. Let's watch a movie, slideshow. Can you see this placenta and the myometria? Can you see the myometria layer there? There's a clear zone, and then there's still the myometrium there. Can you see the myometrium and the clear zone? So next one, placenta lacunae versus placenta lakes. So it's quite interesting. I'll start with a little bit of video. Can you see here? With the legs, these are the placental legs. And then with these placental legs, when you press with the probe, they disappear. And then with the placental lacunae, you press on it, nothing happens. You cannot completely make it disappear. They're non-compressible. And if you put like a little Doppler on top, it will be a little bit high velocity. And it might look like a moth-eaten appearance. So let's read through that. Location. If it is placental lacunae, because it's mainly with the attachment, they will be near the basal plate. Near where rather than near the baby, it will be near the myometrium basal plate, the little lacunae, whereas placental leg are more central within a cotyledon. So there's like one cotyledon, there's like a little leg there, or in between cotyledon in the middle. Appearance, usually with the lacunae, they are like irregular, jagged, moth-eaten appearance, or like Swiss cheese appearance, whereas these could be like large color Doppler flow. If you put a Doppler on it, peak systolic velocity will be more than 10 centimeter per second because they come directly from the radial or arcuate arteries. Whereas with the placental leg, it will be low flow or no flow. And this is quite where I like it. With probe pressure, it's non-compressible if it is lacunae, whereas placental leg usually disappear or change shape with the pressure. So lacunae are commonly seen with invasive placenta, we suspect it, whereas placental leg are quite common in the late first trimester onwards, normal pregnancy. Underlying cause, abnormal placenta invasion into myometrium, whereas this is just one of the spiral artery that goes into the endometrium, gets large, and then it just increase flow to that cotyledon. It will not affect the baby in any way. Whereas lacunae will be a reflex sign for PAS and needs further imaging. Let's see more pictures. Can you see here? With the normal placental leg, they could be quite like big leg, but the blood vessels supplying it will have low flow. They don't have this like moth-eaten appearance like the lacunae. So this is like a spiral artery feeding a normal placental leg. As they can be like compressed and they become changed in their shape when you press with the bladder probe. With a probe, whereas here we've already seen this one before. The placental leg, when you press, they disappear. Disappear here. Okay, next one. Whereas with the lacunae, you press there, and then it's still there. It's high flow. Okay, next one. So bladder wall disruption. So essentially there's the bladder, placenta, and then there's like a little bit of, can you see where the bladder wall has been disrupted? It's quite easy to see. Loss of normal hyperachoid line. That is a little bit, the bladder serosa interface is always white. That hyperachoid line disrupted. If it is disrupted, it's usually quite severe Accreta spectrum, Accreta. Next one is exophytid mass or placenta barging. So this is like a uterus, and then this placenta barging can be seen in the scan like this, like a bladder. There's serosa bladder interface is disrupted here. You can see the placenta invasion and this exophytid mass. So that's Accreta, severe form of Accreta spectrum. Okay, now these are more like color Doppler signs. We said hypervascularity can be seen in utrovesicle between uterus and bladder, and also retroplacenta. So this is bridging vessels are seen as color Doppler signals arising in the myometrium, crossing the uterine wall into the bladder. So it starts from the myometrium, cross the uterine wall, and then into the bladder. It's like this little, like a vertical mark, bridging vessels. So it means neovascularization. There's new blood vessel formation. So it's hypervascularity and bridging vessels can be seen. You can see these lacunae are not going away. So this is lacunae, bridging vessels, hypervascularity, bladder invasion. Possibly this bladder is intact. Okay, next one. This is retro or subplacental hypervascularity. Subplacental blood flow normal versus hypervascularity, demonstrating feeder vessel into the non-compressible placental lacunae. So this is normal blood flow, whereas abnormal, you have this like lacunae, and then it's like really vascular in the retroplacenta area. It feeds into the lacunae. So this is to sum up essential signs for the detection of PAS. So 2D grayscale signs. So usually we start always with that loss of clear zone, the placenta, and then we press and then release. There should be a black hypoechoic zone, clear zone. If it is lost, and then behind the clear zone there's a white layer myometrium. How thick it is, it needs to be quite substantial size. If thin, less than 1 millimeter, or completely lost, and then we go back inside any placental lacunae. Is it leg or lacunae, breast? Is it non-compressible? Is there like a little feeder vessel into the lacunae? And then is there anything inside or outside? Is it getting interrupted into the bladder wall? Did that like bright serosa bladder interface is gone and bladder wall was interrupted? Or the whole placenta barging outside, or exophytid mass? And then we put color Doppler on it. So we look at hypervascularity all around between the uterus and the bladder, and between the placenta and behind the placenta, and then especially between the uterus and the bladder, there's bridging vessels like a little vertical lines. And then inside there's any lacunae, feeder vessels with high velocity flow, more than 10 centimeter per second peak systolic velocity. And then we can use 3D to see hypervascularity as well. So if we go through all these and routinely use color Doppler, then it's a diagnosis with multiple signs. It increases diagnostic accuracy rather than one single sign. So Transabdominal versus transvaginal imaging. Obviously, each has its benefits. Transvaginal is superior resolution, especially with the retroplacental zone, bladder interface with the bladder serosa interface. Lower uterine segment, it is better, especially if it is posterior placenta. Transabdominal will have acoustic shadowing, so transvaginal is important. And sometimes in some posterior placenta, we might even need MRI for that. So transabdominal has its own use because we can see globally the placenta, the whole placenta morphology can be assessed and mapped, especially if there are some extension on the lateral or frontal placenta attachment. And if the PAS is suspected in those areas, transabdominal would be better. And also with previous cesarean scar, it's better to do it from above with the transabdominal probe. And for that, we need moderately filled bladder, at least 250 to 500 ml, to improve the uterovesical interface. So it's better to combine both transabdominal and transvaginal for comprehensive evaluation. So limitation and pitfalls. Posterior placenta, again, visualization is limited. Transabdominal might not be the best. Try TBS and sometimes even MRI. False positive, we can sometimes see these prominent vessels near the bladder. It could be like, is it Accreta? But start with the simple things like, is there still a clear zone behind the placenta? Is there still myometrium after that? And then there's this like a bright hyperachoate line of the bladder serosa interface. Is it still there? All of these interrupted. Only then with these prominent vessels is most likely PAS rather than just one single sign. So yeah, over-reliance on single feature, never diagnosed with one single sign, is based on multiple markers. So practical tips. We need to optimize the examination, use scalar Doppler routinely, especially with risk factor previous scars, and appropriate bladder filling, at least 250 ml or 500 ml for transabdominal assessment. And then for detailed lower segment assessment, always complement yourself with transvaginal approach. And documentation essentials, we need to document clearly myometrial thickness, and if there are lacunae, how many numbers, size, location, any bridging vessels. And rather than static images, you can see from the cine loops that is much better. So let's say loss of cine loops. And once suspicious features are identified, clear communication with the obstetric team. It's the same for even with fetal anomalies, right? A specific description of findings rather than the general impression. So rather than like suspicious of PAS or something, it would be better to describe like a specific findings. Actually, I'm seeing placenta lacunae, which are non-compressible with high velocity flow, and also I'm seeing myometrium is thin, bladder serosa interface is disrupted. So all the findings need to be documented, and the diagnosis is multiple features rather than single finding. So the more features, the higher likelihood of PAS. Referral pathways and limitation. One, to escalate, we know any suspicion of PAS, if risk factor or even without risk factor, if there are any signs that we have gone through, you see them, we need to refer them. And when also we see them, then we refer them to a dedicated PAS center in St. Mary's. And then communication, again, all the findings documented and recorded with cine loops. And then awareness of limitations. Sometimes posterior, we need to do with TBS or even MRI. And yeah, we've gone through everything. So this is a new thing called a separation sign. It's a novel, like a new ultrasound science for ruling out an PAS. It was published recently in 2022. So what is this? Essentially, it relies on the elasticity difference between the placenta or the endometrium and the myometrium. So probe pressure, when we press and then release, the myometrium is very elastic, so it snaps back like very quickly, whereas placenta and endometrium, they are like slow to come back and continues moving. So there's more separation. That clear zone, the retroplacenta clear zone, become more clear. So positive separation sign mean the placenta layer and the myometrial layer separate. So positive sign means positive separation sign. So they separate easily on scan when we see it. That means during delivery, after delivery, they are more likely to separate. So the risk of them more adherence or becoming PAS is less. Whereas negative sign means negative separation. So the endometrium, placenta, and the myometrium are not separating. Then they are like moving as one unit. So if they are not separating on scan, they are unlikely to separate after delivery and more likely to be stuck placenta, PAS. Uncertain signs. So this sign is important in the sense that if you can see a positive sign, it will reliably exclude it's not PAS. But if you cannot see it, if you are not sure, then we can have more assessment. So do not say it is positive unless you see the separation in or across the placenta. Not just one area that's separate, but this layer is not separate. So it could be focal accreta. So we'll still say uncertain sign or negative sign in that case. So how do we perform? It's transabdominal. So full bladder 250 to 500 ml transabdominal approach. We'll use an E8, E10 technique. So we identify the uteroplacenta interface, the clear zone, and then apply firm pressure over the placenta. And then the clear zone is gone, pressed together, and then release very quickly. And then positive sign is when there's positive separation between myometrium and the endometrium, there's a black line, bounce, positive. If they are moved as one and there's no clear zone, negative sign. So it should be assessed the whole placenta. Let's see this video.
This is an example of the positive separation sign. This sign is a reflection of the difference in elasticity between the muscular myometrium and the placenta. After the placenta is compressed against the myometrium, when the pressure is released, for a brief moment the placenta appears to continue moving after the myometrium has become stationary. You can see this at the tip of the yellow arrow. The placenta appears to keep moving and the clear zone is briefly enhanced.
You can see little movements here. Can you see these little movements when they release?
This is an example of the positive separation sign. This sign is a reflection
Before this, let's go through the negative sign. So let's play the video.
This is an example of the negative separation sign. The arrow is pointing at the interface between the myometrium and the placenta. You can see when the probe pressure is applied and then released, there is no clear zone becoming apparent and the placenta is not moving separately from the myometrium. The important thing that you've got here is that both structures are moving as one. When you look at the positive separation sign, the myometrium is released and the placenta continues to move slowly afterwards. Here you can see there is absolutely no separation between either of them and both structures are moving as one.
Okay.
This is an example.
So what is the clinical implication of the separation sign? Let's start with the clinical impact. So it's a rule out tool for PAS. We cannot diagnose PAS with the separation sign. As we said, to diagnose PAS, it needs to have multiple signs. This is to ruling out. So if it is positive sign, we're quite positive that the placenta will separate after delivery, so it's unlikely to be PAS. So we will have more conservative approach in our obstetric management, and it will reduce maternal anxiety and iatrogenic complication. Like sometimes we might plan to remove the uterus at the same time as cesarean section. Sometimes we might go into uterus with classical or funded incision to get more space. Sometimes we have interventional radiology. All of these can be avoided by reducing the overdiagnosis of PAS, by ruling out PAS, and unnecessary resources, use of resources will be reduced. So that is a good thing about separation sign. So how good it is? Specificity is 100%. So if it says that it's unlikely to be, it's usually right, I think. But the sensitivity is 98.2% because PAS cannot be diagnosed with just one sign. So not very sensitive, but specific in excluding PAS. So when do we use? In high-risk patient, it can be easily done. Placenta previa or anterior low-lying placenta or with previous scar, we can use this sign, and hopefully it will help us in ruling out PAS. So these are my references if you are interested. On the Fetal Medicine Foundation, there's a course for placenta accreta spectrum. You can finish the theory and get a certificate. And also on visual, on Israel, there's a VISUOG video for the Israel chapters, and it's a really good chapter as well. Separation sign, this is the paper for that. Placenta lake, vasa lacunae, and simple guide for the assessment of placenta accreta spectrum. These are my references. Thank you everyone for going through this long lecture.